Hey, welcome everyone, and thank you for joining today's SADS Foundation webinar, September 23rd, 2025. Today's webinar is medication, medication safety with long QT. I'm Marcia Baker, the program director for the SADS Foundation. Today's webinar is the second part of a two-part series with CredibleMeds. The SADS Foundation has had a long-time relationship with CredibleMeds for many years. The founder, Dr. Ray Woosley, is one of our scientific advisors, and we're extremely grateful for his team, including his daughter, Kissy Black, who is on the webinar tonight. It's my pleasure to introduce our speaker and welcome him back to a SADS Foundation webinar. This is his third webinar he's done with us, so he's back by popular demand. Dr. Will Heise, a medical toxicologist and family physician, who joined the faculty at the University of Arizona in 2015. Dr. Heise's been a member of the CredibleMeds Scientific Review Board since 2016, almost 10 years ago. We're honored that Dr. Heise is volunteering his expertise and time tonight for the SADS Foundation. Following his presentation, you may ask any question by posting it in the chat, and Dr. Heise will address them at the end. A reminder that this webinar is being recorded, so please keep your audio muted. The webinar recording will be emailed to all of you in a few days. So a reminder that part one of this webinar series was recorded last week with the CredibleMeds team. And in that recording, we had the CredibleMeds mobile app developer, Mr. Keith Simmons. He joined us to demonstrate the mobile app that he developed as a patient living with long QT in the UK about 10 years ago. So welcome, Dr. Heise. I'll turn the program over to you.
Thank you, Ms. Baker. I appreciate it very much, and I do appreciate the chance to talk to all of you about this. We are going to go through mainly some medications, talk a little bit about mechanism today, and a little bit of sort of common sense application of selection of medications to avoid drug-induced arrhythmias. Some of the things that we're going to talk about are those for which there is limited evidence, and I'll try to be clear about that. And for others, there's very clear evidence that they cause drug-induced arrhythmia. And so in almost all cases, those medicines should be avoided when possible. Any of the medicines that we're going to talk about today might be something that folks who have even a family history or a personal history of sudden arrhythmic death or the risk for that should potentially be on at some point after you've talked to a doctor, because there's some of these that are very difficult to avoid and that are incredibly helpful in certain medical situations. And so, when we talk about these, we're going to talk about them in terms of risk, but I don't mean to demonize them. I think that's one of the things as a medical toxicologist that sometimes I can fall afoul of, is that there are some medicines that I continually see adverse effects, or I see overdoses of them or problems with them. That doesn't mean that they're not great meds that should be used in certain situations. So please remember that there are certain situations in which you might choose to take some of these, especially with careful monitoring. So first of all, I have no conflicts of financial interest with anything that I'm going to discuss today. In full disclosure, I'm a board member of CredibleMeds.org, and I think that this is an incredible organization that has done spectacular work over many years in looking at the risk of drugs to cause arrhythmia, and I hope to be involved with them long term. And then I'm a faculty member of the University of Arizona in Phoenix, Arizona. I'm an associate professor there, and that's my primary roles. So, as I said, we will review the safety and a little bit of efficacy of commonly used medications, and we're going to talk a little bit about cold and flu supplements with that season coming up, and then we'll look at some of the limitations of the current information. So, as you probably all know, but just in case there's someone who doesn't, there are many variations of ion channels, and that the most common sort of ion channelopathies that result in problems with drug-induced arrhythmia are those of potassium efflux and sodium channels, but that there are many others, and that this is not necessarily true for everyone. But in general, these are the kinds of medicines that have definitely not only been associated, but for which we believe there to be a causal relationship with drug-induced arrhythmia and should in most cases be avoided. All right, so we're going to teach you all everything to know about the uh, um, uh, cardiac cells here and the signaling that goes across them, which is, of course, not entirely true. But just to briefly review, remember that the primary electrolyte that shifts in the cell during the time that it begins to contract as a cardiac myocyte is sodium. And that sodium, through a very, very carefully balanced mechanism, floods into the cell from outside the cell, and that we spend almost 2/3 of the energy that we use in our entire bodies to build this particular electrochemical gradient. And it's this huge amount of sodium coming in that then results in the opening of calcium channels. And it's actually the calcium that goes to those portions of the cell that contract, and that calcium binds to actin myosin and causes actual contraction. Well, then, as it turns out, we've taken this cell and we've contracted it, but we need to return it to resting so that we can beat again in, a half second or maybe a whole second. But that has to happen quite quickly. And what we do is we actually allow potassium to escape from the cell through potassium efflux, is what we call it. And that returns the cell back to resting. So what we see on electrocardiogram, if you've seen these, is this is the sodium and calcium wave, and then we see a potassium wave, if you will, here. And that returns the cell where it's ready to do this whole thing again. And that any aberration in this results in a long contraction of the myocyte and leaves it in a state where it can be prone to have accidental extra contractions, which is what actually results in arrhythmia. And that it's this potassium flow and this return to its ability to go back and do the whole thing again in a very short time frame that, when it is abnormal, results in many of the drug-induced arrhythmias that we are facing in this group. Now, there are many medications which are not brought to market because of the risk for torsade and other drug-induced arrhythmias. This is an entire list. Some of these drugs you may or may not remember, which actually made it to market, were somewhat helpful, and in some cases were taken off the market only after a really long and careful discussion because there were other alternatives that could be used, and these drugs had too high of a risk. So the classic example is terfenadine, which is Seldane, which was a medication that was used in the 80s to treat allergies. It was incredibly effective at treating allergies, but suddenly we had an abnormal number of young women having arrhythmias, and it was found to be secondary to this particular medication. The interesting thing is that terfenadine is closely related to fexofenadine, which is on the market today. But fexofenadine has only one of the enantiomers, which are sort of the different shift of these molecules, and that treats allergies great, but without this added risk for arrhythmia. Another sort of famous one is cisapride, which is a medication that was used for gastroparesis and folks that had guts that didn't work properly. And there was a long discussion as to whether this could be taken off of the market. And in the end, it was taken off because of its high risk for drug-induced arrhythmias. Interesting, as someone who lives in Arizona, I see toxicity from this drug not terribly infrequently because it's still available in other countries, including Mexico. So when we evaluate drug risk at CredibleMeds, we categorize medicines and we place them into, well, really 4 categories, right? One is no risk. One is conditional risk, and this means that it causes interacting factors that can be changes in electrolytes or changes in how other drugs are metabolized that can potentially cause arrhythmia. And then we have the known and the possible risk. So if a drug is demonstrated to change the QT length on an electrocardiogram, we put it into the possible risk list. And that means that it does in fact change QT, or that's mentioned on the label, but that we haven't been able to prove a causal relationship with drug-induced arrhythmia. We're going to talk today and next about those that are in the known risk. And this means that there are definitive cases in the medical literature, or that a number of cases have been reported to the FDA adverse event database. That has resulted in an abnormal signal, and that we go and we look at that in a fairly highly statistical manner in order to make sure that it's real, and that it happens with folks that across the board. So those ones that are known to cause arrhythmia are those that we're going to talk about next. We've published the mechanism by which we do this in the medical literature, and if anyone is interested, this is that one. All right, so we're going to talk about some drugs that can cause torsades de pointes. And the first ones, one of the easy ways to remember this, which is not easy as you'll see, is A, B, C, D, E. So the first thing is antidysrhythmics. So in a complete fit of irony, those drugs that are meant to change the electrolyte and ion flow across the heart can result in a higher risk for torsades de pointes. Now, you, of course, should be aware that many folks that are on this call, or they may have loved ones that are on some of these medicines, and those are really carefully chosen and thoughtfully picked as a result of what maybe your particular genetics are. But in general, if you have someone who doesn't know about that situation, or you're going in and it's being treated independently of recognition of that genetic risk for torsade, these are the kinds of drugs that can take a quote unquote normal person who doesn't have any genetic differences in their ion channels and can make them have torsade. And so those should be very carefully monitored and taken care of. The B in our ABCDE is antibiotics. So you'll notice that the first one I used anti because it makes my life easier. This one I chose the second part, which is biotics. So classically, these include some really commonly used medications like macrolides and fluoroquinolones. So macrolides, a Z-Pak, for instance, contains azithromycin. And again, it's not as if everyone who takes azithromycin who has family risk will keel over and die. But there are approximately 1,500 excess deaths in the United States, America, and Canada in any given year purely from antibiotic use. And that in comparison to, let's say, amoxicillin and the macrolides. And that's been very thoughtfully published and carefully studied. And so these do definitely have excess risk for drug-induced arrhythmia. And fluoroquinolones are very commonly used for, and that's basically anything that ends with fluoxetine. So you may see these used for pneumonia or urinary tract infections in those kinds of settings. These are among the most commonly used antibiotics, and so should be you should be really thoughtful about taking those. That leaves us in the C of, so these are antipsychotics, again, reaching a little bit, but I'm trying to do my best here with a mnemonic device. These include medications such as haloperidol, ziprasidone, and droperidol. Many of the sort of newer psychotics that are available, if you will, new age, new class ones, things like quetiapine or Seroquel or aripiprazole or Abilify are really commonly used. And those do have some risk, but not as much as sort of these classic medications. And again, careful thought should be placed in terms of medication selection to control thought disorders and severe mood disorders while still not causing drug-induced arrhythmias. Next is antidepressants. So many of the antidepressants are selective serotonin reuptake inhibitors, or SSRIs, and many of them are quite safe. You just have to be a little bit careful because a really commonly used one is Celexa or citalopram, which otherwise are really great medicine and very viable for lots of folks. But in those that are at higher risk, this is not a drug that I would use. And then tricyclic antidepressants, which are the ones you might see the most commonly are amitriptyline and nortriptyline. And many of these medicines are no longer used so much for its antidepressant effects because they have a lot of side effects and they have a lot of, they take a very high level in order to have their antidepressant effect. But they're used for chronic pain, for neuropathic pain, for sleep disorders, for pruritus or itching from various and sundry things. And so you have to be a little bit careful that many of these will be used off-label very reasonably and with thought. And I will use those tricyclic antidepressants for some of those off-label uses. The reason that they don't have a label for it is because they're old and cheap, and no one is paying for them to go and get those label indications. They are not Ozempic, right? And then antiemetics. I decided it was close enough to October to use this image, but these include droperidol and promethazine. And ondansetron is also not without risk, which is Zofran. And ondansetron or Zofran is one of the most commonly used medications in the United States of America today. Something like 25% of all persons who are in the hospital will receive that medicine. And again, it's not that you can't receive these, it's that they need to be carefully thought through, and that the risk versus reward assessment should be done. And then, of course, there are others, methadone, which is used for the treatment of opioid use disorder and is a great medicine for that, and cocaine, which is, of course, a category 1 in the United States and has no like legal use other than perhaps as an eye anesthetic, very, very rarely. So that one shouldn't be an issue in most settings. I mentioned that there are some medications that can cause conditional risk. We won't go into these specifically, but just to reiterate, those are medicines that in and of themselves don't necessarily directly cause arrhythmias, but which can cause an alteration in electrolytes like magnesium and potassium and calcium that are really important for cardiac myocyte signaling. Those that can change drug metabolism. So classically, this is the grapefruit juice conundrum. I live in Arizona. We have a ton of grapefruits that come around the beginning of the new year into season. And we'll be drinking a lot of grapefruit juice, but that does interfere with a lot of different medications. And some medicines that are safe in some amounts, you can be taking the same amount by mouth, but you might have a lot more floating in your system through changes in drug metabolism. CYP is short for cytochromes, which are in the liver and metabolize most medications. And then, of course, lower heart rates are associated with a higher risk of drug-induced arrhythmias. That's because of the longer recovery time of the cardiac myocyte. And so anything that can make your heart rate really slow could potentially cause issues. So just a brief word about supplements. I oftentimes get a lot of really good questions about supplements in these talks. And so I wanted to make sure that we kind of have some general rules for these. And remember that in spite of the fact that that I might happily buy this one as well, this fish oil, because it is safe and probably somewhat efficacious, that they are very loosely controlled, and that efficacy doesn't have to be demonstrated, and that just because they come from Costco, where I like to buy my steaks, doesn't mean that they're necessarily safe, and that contaminants are really common, and that they tend to be mixed with other things, and that there might be the presence, unlike certain FDA regulated drugs, supplements are not carefully tested in most cases to make sure that they contain what they're supposed to contain. And it's not uncommon to have other kinds of things in them. And so, again, this is not to say that you can't ever take a supplement, but this is to say that remember that what you take this week, even if you get the same thing next, may not be exactly the same. And so that should be done with careful thought and not doing it in such a way that it can be potentially life-threatening. So we have a few medications that are a few supplements in particular that often come up. The first one is vitamin C. So vitamin C is great for you. It is water soluble. So if you take excess, it will be eliminated in the urine. Essentially, there's like kind of a limited amount which your body can absorb. And if you take more than that, that is fine, but you will just urinate it out. A reasonable amount of vitamin C is very likely safe based on studies of drug-induced arrhythmias. Remember that if you have large quantities, they may interact with medications. They tend to be formulated sometimes with calcium-containing tablets. And so a huge amount of calcium has a charge, an ionic charge associated with it. And that can bind certain kinds of medications and may make them less absorbed than they are otherwise. Zinc is a really common sort of supplement. I'm trying to think of what it is. There's Emergen-C, which is like the C vitamin one. There's some zinc ones. I don't remember what they're called, but they have really catchy names, of course. And it is, in fact, true that early supplementation with zinc in some cases may help decrease the duration of colds. The data is limited, but is there. If you start to taste zinc when it's not in your mouth, you probably overshot the mark. So this is, you have a large amount of sort of like metal floating in your bloodstream, you can taste it. And of course, this has pennies, which these days are a tiny coating of copper on top of zinc. So there's limited evidence on this, but it's probably safe. In a fit of irony, if you swallow enough pennies, you will actually become copper deficient from the huge amount of zinc binding up all the copper inside your body. So it's sort of funny that you can swallow something that looks copper and that you can end up copper deficient because of it. I've seen that in a few little kids that have a tendency to eat large quantities of things that they're not supposed to eat, whether that's dirt or ice or pennies. Echinacea. So this is, of course, a very popular cough and cold remedy. Honestly, if you look at the data, it probably isn't particularly helpful to the point where, I know it's popular, but I think that the risk-benefit ratio is a little bit too high given the potential for other ingredients and herbs inside most echinacea-containing supplements. So if I was going to pick one, for my cough or cold, it would be zinc and vitamin C before echinacea. Garlic is, of course, very popular as well. There is some limited observational evidence that sort of taking garlic before you get sick might help prevent it. I prefer to receive my garlic in the form of marinara sauce, but you can receive your garlic in any way that you would like. That's why I put that it was yum. So moderate dietary amounts are certainly safe. There's never been any demonstrated increased risk of arrhythmias in populations that use a lot of garlic in their cooking. Otherwise, all the Italians would be dead, right? And you smell amazing, and your vampire worries are, of course, minimal when you're taking large amounts of garlic. So garlic might be helpful as sort of a steady part of your diet, but supplementing large quantities of garlic is probably not particularly helpful. It's probably safe, but it's probably not helpful. Elderberry is one of those things that has come out as sort of a, I don't know, newer wave, I would say, in the last 5 years. There is some limited randomized control trial evidence that it can be helpful, especially when traveling. I think famously there was a study where they gave this to people, I think they were older individuals who were traveling back and forth to Australia in like planes for long periods of time with lots of people, and demonstrated that those folks who were traveling, who were using elderberry, were less likely overall to become ill than those that were not. So that's very interesting. Again, the same things apply of making sure that what you're getting is actually elderberry. So I would want a high quality source. And of course, one of the things that I think is really challenging in this setting, we say that it would be nice to have a high quality source, but determining, everyone's website says that they're a very high quality source, but there are some good objective groups out there that do testing and that don't take money from the manufacturers. And I would utilize to see what it is. And a recommended dose of this is about 300 milligrams. The other thing that I often get questions about is anxiety treatment. I always recommend a stepwise approach to this. We do have on CredibleMeds, on the main website, there's a link, and this is the direct link as well, to medications for which we have reviewed for certain kinds of diseases and processes, and which we found to be safe, or at least to lack any evidence of harm, which is to say as safe as we can possibly get. And so I would suggest that you use that when you're looking at options. And so you can look up something like anxiety, or you can look up something like a cold or weight loss. Any of those things can be checked on the website, and some safe alternatives to certain medications will be suggested. So when you have an anxiety disorder and it's a generalized anxiety disorder, then I usually recommend like buspirone and duloxetine and SSRIs that are excellent for long-term control. For short-term control and panic disorder, benzodiazepines can be used. But of course, benzodiazepines, while safe in terms of drug-induced arrhythmia, which is great because we use them for so many things, do have a high risk profile in terms of dependence and addiction So even if you don't get addicted, if you regularly use benzodiazepines, you will become dependent upon them. And their signaling is very similar to alcohol. And so it has a similar kind of potential risk profile, if you will, as alcohol dependence and tolerance over time. We, of course, already mentioned avoiding citalopram and the tricyclic antidepressants in this. While I'm thinking of it with therapeutic options, it does seem as if GLP-1s are pretty safe, since that is a very popular thing to use right now. There's no evidence that it causes abnormalities in electrolyte balance as long as a normal, like healthy diet in smaller quantities is taken. And there's no evidence that they seem to cause drug-induced arrhythmia, which is great because I think GLP-1s are excellent and something that is a good thing that we have in the United States today. Magnesium. So magnesium is a supplement that, of course, is sometimes used for anxiety. There is really good evidence that those who are deficient in magnesium, that this can help with their anxiety. And in general, a low dose is probably quite safe. I think at really high doses, you can cause ion channel changes. And we know this is true because when we treat preeclampsia in pregnant women with magnesium, there's a certain amount that's really safe and helps calm everything down and prevent seizures. And then when you overshoot the mark, even in like normal, healthy young women, we can reach a dose that is causing ion channel changes and that can result in, not breathing and death. So there's a moderation there. And again, if I was going to tell you the primary takeaway, it's common sense should reign in most of these situations. All right, that is Lost Dutchman State Park, just east of here. It's beautiful. Probably best enjoyed in the months after this month and before April. If I could recommend it to you, I would do that. So I think we're gonna take some questions and some ideas here.
Thank you very much, Dr. Heise. Very comprehensive. And yes, this is your opportunity to post questions into the chat feature. I'll read them and Dr. Heise will address each one individually. So go ahead and post your questions there in the chat to everyone.
We usually get a lot, so that's why we plan to have half the time for initial presentation and then some time for this.
Exactly. Okay, here's one from Vera. I don't know how to pronounce it. Is Asofex okay or GERD?
Yeah, in general, so Asofex is rabeprazole, which is one of the proton pump inhibitors in that same category as omeprazole and pantoprazole. I'm trying to think of what their brand names are. Nexium, I think. And this is a really commonly used medication for GERD and other reflux. I suggest that these medicines are used for in the lowest possible dose for the shortest time frame possible. I think that one of the things that we've realized is that in the United States of America, we have put folks on proton pump inhibitors and left them on them for many, many years without changing that. And that can certainly lead to electrolyte deficiencies and abnormalities, in addition to higher risk for osteoporosis and other diseases. So there's no particular thing other than it might change some of your magnesium and other absorption of electrolytes. But in general, for everyone, and in particularly for those at risk of drug-induced arrhythmias, I would use the lowest dose for the shortest time frame that is possible.
Okay, thank you. Do you have a list of sites that you use to determine which supplements are from a high quality source?
Yeah, that's a good question. Let me look because I was trying to, even as I was saying that, I was trying to think of what it was. There is one, there's something called the Natural Medicines Comprehensive Database. That is a really good clinical decision support tool. So that's the Natural Medicines Comprehensive Database. And the NIH also maintains a list of dietary supplements and their products. Let me put that into here. This is the NIH one. There's that link there. and that one is quite good. So I would suggest the Natural Medicines Comprehensive Database and the NIH one as some place to start.
Okay, thank you. So any issues with ibuprofen? I've heard in recent years that acetaminophen is
Yeah.
preferred, but I do not know if it's due to any long QT reasons.
All right. And I agree with Jennifer on her answer on this one. In general, ibuprofen is fine. Ibuprofen and other non-steroidal anti-inflammatory drugs, which include things like celecoxib and aspirin, are quite safe from the setting of drug-induced arrhythmias. They can, in heavy use, cause some kidney dysfunction, which is, of course, in and of itself potentially problematic in this setting. But that is with really heavy use. So normal, as the container says, use of acetaminophen, which is Tylenol, or ibuprofen and other NSAIDs is generally just fine.
Okay. All right, thank you. Let's see, any over-the-counter cold medicines or decongestants that are okay to use with long QT?
Yeah. So this is, you're going to be disappointed in that most of the things that are sort of the most, I mean, honestly, what's actually efficacious, um, you know, they're, I think basically it's Sudafed or pseudoephedrine, which I certainly wouldn't take in this setting. I suggest things that have relatively little, like honestly, guafenicin is probably safe, which is Mucinex, but it really doesn't do much if you look at the actual data. Neti-Pot or sinus irrigation actually can be somewhat helpful for people. So I mean, I guess I would go with the usual supportive care, Tylenol and lots of fluid and, wait for it to get over. Most of those decongestants, including things that are antimuscarinic, that are stuff like Benadryl, um, you know, is on that edge where to me it's not worth the risk. This might help clear up some of your congestion. On the other hand, congestion is 100% survivable. And to me, the risk benefit ratio is not there for almost any of those cold medications and decongestants. So I would really do supportive care, lots of fluids, and Tylenol, and just roll with it. Sorry.
Thank you. Are there safer inhalers to use for asthma?
Yeah, so asthma is an interesting one. So in general, inhaled corticosteroids are quite safe. And most of the sort of um, the recommended control of asthma and other obstructive lung disease like COPD includes inhaled corticosteroids. They have relatively little systemic absorption and side effects, and they're quite effective. If you're thinking about albuterol, then albuterol does cause tachycardia. And we mentioned bradycardia is actually worse for arrhythmias than tachycardia. It's not 100% safe, but again, here we're talking about risk-benefit ratio. So if your alternative is that your airways are collapsing and closing up and you can't breathe, well, guess what? It's time to use some albuterol. So albuterol should be used as a rescue drug. In general, we don't recommend long-acting beta agonists, things like formoterol and those kinds of medications for that. There is some evidence that Montelukast, what's the brand from Montelukast? I should know that, and I do. It's just a matter of Montelukast is Singulair. There's some evidence that Singulair is quite safe and can be used as well. So between inhaled corticosteroids and Montelukast or Singulair, and then as needed when severe albuterol, that's kind of where I think I would sit in general. You could have a discussion if you need to be on if you have really severe asthma and you need to be on a long-acting bronchodilator with your cardiologist. There might be some that are fairly safe for that.
Okay, thank you.
Yeah.
Okay, and comments. One of my doctors has suggested I take iron, vitamin D, and B12. But are these okay supplements to take, or should I run it past my EP first?
Yeah. I mean, it never hurts to run it past your EP. On the other hand, I will tell you that I think that those three supplements should be fine. Now, vitamin D will cause some calcium changes, so you shouldn't take like ridiculous quantities of vitamin D. But vitamin D, if you're genuinely deficient and you've been proven to be by the actual like levels that have been measured, can be helpful in sort of maintaining those levels of calcium at normal, healthy amounts. B12 and iron should be, in general, just fine. The usual kind of things about supplements occur or still are true for that.
Okay. Please clarify whether fexofenadine is it safe? Any difference between the brand name and the generic?
Yeah. So fexofenadine is generally safe. It's a second generation antihistamine. The brand is Allegra. And there's really no difference. There's no biological difference between Allegra and fexofenadine. And if you want my personal, like, what do I actually do? If I walk into the pharmacy and I can choose from brand or generic, I buy whatever's cheaper, which is generally the generic, because they're exactly the same. So that's what I do. I buy generic. Everything in my medical cabinet is essentially generic. Um, and it's quite safe because it has this sort of this right rotational enantiomer. So it works like terbinafine used to, but without that effect of potentially killing people. So um, the old one, which was terbinafine, which I forget what the brand name was now, it's no longer on the market, is not safe, and you should not go to Mexico or Poland and buy it.
Okay. Can you speak on the medications for the treatment of ADHD?
Yeah, so ADHD is a tough one. And that's because the best medications that work in terms of just um, efficacy and that have the best evidence that they're good are stimulants. And stimulants generally are not considered safe, and they would be medications to avoid in the setting of drug-induced arrhythmia risk. Um, so I would basically do everything else before you got to that point. There's some evidence that guanfacine and other alpha-2 agonists, things like clonidine and guanfacine, can be helpful in folks. Also, atomoxetine, which is Strattera, I believe is the brand, is probably safer because it does a little bit of more norepinephrine in the presynaptic norepinephrine transporter. So atomoxetine is probably a bit safer than stimulants. It's sort of like maybe the next line. And then if that doesn't control it, then potentially the use of stimulants is reasonable in severe cases, and with like carefully managing that stuff.
Okay, thank you. Our last question so far is any concerns about mushroom supplements?
Yeah, so I think that the data, I mean, again, we're talking about sort of, it depends on whether we're talking about psilocybin containing mushrooms and like hallucinogens, or we're talking about sort of, I don't know, like lion's mane and sort of more normal dietary ones. Personally, I don't think that there's enough evidence that there's helpfulness from any mushroom containing supplements to make it worth it to me. Most mushrooms are pretty safe, but there are some that are known to cause issues with drug-induced arrhythmias and that do cause some ion signaling changes and that are antimuscarinic along the same lines as Benadryl or diphenhydramine. And so I personally don't think that the mushroom supplement benefit is the efficacy is worthy of the risk profile. I will say that the risk profile is low, and if you found a supplement that works well for you for, I don't know, knee pain or whatever it is that you're taking it for, it's probably okay, but there's still always going to be a question as to whether that's worth it in my mind.
Okay, thank you. Okay, Vera, ask your opinion on turmeric, NAC, and quercetin. Quercetin.
Yeah. So I guess we'll just start at the beginning there. So turmeric, of course, we all enjoy it in our Indian food and food from the Indian subcontinent. It's really nice for coloring things, bright yellow and orange. It is probably overall safe in this kind of setting and may have anti-inflammatory effects. My parents went through a phase where they swore by it. I think they still take some, and it's probably overall pretty safe. I think that the efficacy in observational studies shows that there might be something that's helpful there. On the other hand, you can just eat some curry too, which is delightful, and just go with that. So, NAC or NAC, which is N-acetylcysteine. Um, so NAC is actually something that we use as toxicologists to treat acetaminophen overdoses. So your body has a large amount of what's called glutathione inside the liver that detoxifies certain agents. So the idea of NAC is to help that liver work to detoxify agents by sort of restoring that glutathione store. Um, in terms of safety, it's probably quite safe. It's an incredible antidote for acetaminophen overdose in those persons who are, generally taking it to harm themselves, but maybe they're taking 20 or 50 times the normal dose. So it's not as if you need it to detoxify at your normal setting. And to give you an idea of what it is, if I have someone who comes in with an acetaminophen overdose, and they present within 8 hours of, I can take, we can have Marcia eat a whole bottle of acetaminophen, a whole Costco bottle of acetaminophen in front of us there. And as long as we get her some N-acetylcysteine and treated within 8 hours, her liver has plenty of glutathione stores to handle detoxifying all of that, any amount. And so the amount that you're taking compared to the quantity that your liver already has to detoxify and naturally creates is really quite low. So NAC is safe. It's sort of a natural product. But whether or not it really does anything, I think, is up for debate. I don't know much about quercetin. I don't even know if I'm pronouncing it right. Quercetin? I don't know. I'm sorry. That one I don't know a lot about. There seems to be some observational evidence as I'm literally looking at it right now on PubMed, because I don't know anything about it, if the truth be told. So it's telling me it's a flavanol that's found in certain kinds of products. Things that are found in berries and nuts and those kinds of things are generally good for you. Um, I don't see any data on QT changes or drug-induced arrhythmia when I do like my standard search on it. So I'm going to say that within the limits of this being the first time that I've thought about that, I don't see anything that it probably is safe, but I don't know anything about the efficacy there.
Okay, thank you. So Genevieve, our Director of Family Support, Research and Advocacy, asked if do you have any suggestions on how to have a conversation with your doctor about taking a medication on the list. Many of our SADS families need treatment for mental health or other conditions, but doctors are afraid to prescribe anything on the list.
Yeah. I mean, I guess I have a couple of suggestions about that. It's sort of like the quercetin question for me, and that's that I don't know about that. I don't know. Nobody knows everything about all these risks and what it is. And so my suggestion would be that A, you have a doc that you've known for a long time and that knows what your actual genetic condition is, and that has spent some time thinking about it, that you talk to about this, or an electrophysiologist who should be an expert on it. And the second thing would be that you don't, to the best of your ability, that you don't ambush them with it. And I don't mean ambush in like a negative connotation way, but I mean, wouldn't it be great if you had sent a message to your doc beforehand and say, hey, doc, I'm thinking about this. Here's what I know about these drugs. This is what I could find. I'm looking at this CredibleMeds.org website and trying to evaluate the risk. I'd love to have a conversation about this together. Because then your doc has a chance to go in, read about it, prepare, and be really thoughtful about that process. I think go into your average family doc who has a lot of things on their mind, a lot of stuff that they're worrying about, and is trying to diagnose, the kid with the cough in the room next to you, and then talking about these sort of really complex cases. I would give them a chance to think about it or to evaluate that. So I think that if you have a relationship, and then if you give your physician a little bit of time to go in and pull up some good resources and ask AI about it, that's a joke. But prepare for that discussion. I think that that's going to be the best possible discussion, as opposed to just like popping the question to them right then and there.
Excellent suggestion. All right. So Anna asks, is vitamin D at 4,000 IU daily a high dose? She's had 2 cardiac arrests and is extremely cautious.
Yeah, so 4,000 is a lot. The daily recommended intake is 400 for kids and about 800 for older persons. And so that represents quite a high dose. Um, if you're supplementing it closer to sort of the daily recommended amount, which is something like a fifth or a tenth of that, is probably better. Um, most supplementation that I've seen is up to 1,000. 4 is pretty high. So I would keep it well under that personally.
Okay, thank you. What is an alternative to Zofran for surgery from Diane?
Yeah. So I'm going to assume this is referring to post-anesthesia emesis, nausea and vomiting. Um, and so Zofran, as I said, is a known risk drug, but can be safe in some certain settings. And frankly, has probably the best evidence in terms of actually making people vomit quite a bit less. There are some drugs that aren't on the known risk list that like metoclopramide, which is Reglan, which may be somewhat safer. They are on the possible risk list. They've been shown to cause QT, but not that. Some of the other things that you can do are more non-medication intervention kinds of things, like smelling peppermint and having blow-by oxygen for you. Making sure that you have like a calming environment. All of those things are actually really helpful in terms of mitigating post. I was just looking now. Wonder, hang on. Um, uh, I was looking to see if there's anything else I would suggest there, as I look at the alternatives. What else has interesting evidence here? There are some sort of like non-medical interventions that you can do, non-pharmacological stuff. Ginger has some good evidence, as I'm thinking about it. Making sure that you're adequately hydrated beforehand, maybe getting a little bit of extra that. We mentioned peppermint oil, aromatherapy, various kinds is helpful. There's some limited evidence around hypnosis, for acupoint stimulation, particularly in pregnancy, but somewhat as well for post that. Um, so it's really like optimal hydration, ginger, peppermint oil, um, calming room, good hydration. Those things are all helpful and non-pharmacological in terms of treating and avoiding the use of Zofran or ondansetron.
Okay, thank you. So Callie asks, should the medications on the list be listed as quote allergy on our medical records? Or only if we have had a bad reaction to the specific medication on the list?
Yeah, this is complicated. I mean, I guess I suspect that the best way to prevent yourself from getting these accidentally is to put them on the allergy list. I hate to say that because then you get an awful long allergy list. But on the other hand, it's not as if we as physicians never use anything that's on the allergy list. We just use it more carefully, or with thought as to what that allergy actually is. And so listing some of these common medications as an allergy, and that the adverse event that you have, because generally electronic medical records let you list an adverse event, and putting long QT syndrome or sudden arrhythmic death risk, is not a bad way to do this. You know, it would be nice if there was a perfect solution, but probably allergies is a pretty reasonable solution here. All right, then we have a question about that vitamin D thing again.
And
Probably should step it down a bit.
yeah, any concerns about 1700 mcgs of folate for homocysteine?
Yeah, I mean, so homocysteine levels are often also high in B12 deficiency. So I want to make sure that B12 deficiency has also been adequately addressed if it exists. Let's be honest, in most modern US diets, we actually get a fair amount of B12 and folate that have been supplemented into foods, particularly folate because of the connection with uh, neural tube defects in women who are pregnant, who are going to be pregnant. 1700 is fairly high. You know, again, I check for B12, but there's nothing that suggests that a large amount of folate is going to necessarily be problematic for you.
Okay, thank you.
Yeah.
Brandy comments, my husband and 2 teen children have recently been diagnosed. Should we notify the pharmacy so that they can flag possible potential problematic meds?
Yeah, I mean that's one solution. I think the other one would be to carefully check when you get a medication, and you probably want to do that anyway. I mean, I don't know if it would be worth, you know, it's one of those things where like if you're going to use the same pharmacy every time, all the time, maybe that would be worth your effort to let them know about it. On the other hand, sometimes you end up using different pharmacies when you're in different places or your insurance changes or it shifts. So I certainly wouldn't rely, and most of these are medicines that are commonly used and that are safe in the general population. So they're going to pass through a pharmacy with without a lot of consideration, actually. And so my suggestion would be that you in the at the risk of appearing self-serving, you get the CredibleMeds app or something like it, and that you check that list against those medicines when you get them, whenever you're prescribed something new. And that maybe you check them when you're talking to your doctor about what it is that you're going to get next.
Okay, I think we'll conclude on that note, and thank you very much for your participation. Appreciate you as the community asking your questions and participating in tonight's webinar. And Dr. Heise, we thank you very much for your time and expertise and sharing your credible knowledge and the CredibleMeds information.
All right, it was great to be here.
Thank you, and good night, everyone.